for the pain TV. So are we all set, Ashok?
Okay.
All set?
Can we start?
Good. All right. Yeah.
Okay, guys. Okay. So we're live now, right?
Yes, we are.
Okay, perfect. So good afternoon, everyone. Good evening for those who are in the eastern part. I'm glad to lead this session on cancer pain management. Very interesting topic, very important for our patients and for our physicians who are learning and interacting with each other regarding the experience about how to manage cancer pain. Tonight we have a very good panel. We're going to start with the eastern part from Taiwan. Dr. Abdullah Kharabshe is pain physician from Jordan who migrated to Taiwan for some time, and he's getting good time there, learning a lot about pain management. He learned a lot about cancer pain management from our friend CP Ling in Taiwan University, and he's going to talk today about interventions about cancer pain, and we're keen to listen to his lecture. Please, Dr. Abdullah.
Thank you very much, Professor Ammar. Good evening, everybody.
You can share your screen, Abdullah.
Yes, share screen. Yes.
It's recorded, right,
Yes.
Dr. Ahmed?
Yes.
Yes. Yes. Yes, it's recorded. Yes.
Very good. Okay.
You see my screen, Professor Ammar?
Not yet.
Not yet. It's coming. It's going to come. Just green button on the bottom there.
Yes. I put share screen.
Now you muted yourself. So share the screen and then share.
Yes. No.
Yes.
It's good. It's good now.
Perfect.
Thank you very
Great.
much. So today I will talk about cancer pain management, pain physician perspective of view, as pain is the fifth vital signs, and many cancer patients, up to 80% of them, they have a moderate to severe pain. That's why it's a very important topic to talk about the diagnosis and medical management for cancer pain. So in this lecture, on completion of this lecture, we should present epidemiology and pathophysiology of cancer pain, recognize the causes of pain in cancer patients, understand the importance of appropriate diagnosis and treatment of pain in patients with cancer, and understand the principles of cancer pain treatment and the different pharmacological approaches, and the updated new guidelines for WHO and NCCN guidelines 2020. How common is cancer pain? It's common. Cancer pain is common as 53% of patients with disease at any stage, 59% of patients receiving anti-cancer treatment, and 64% of patients with metastasis or advanced stage disease, 33% of patients after curative treatment. Pain in cancer patients in 5 years, cancer survival rates increase because of earlier diagnosis, improved treatment. Optimizing pain management can improve quality of life for cancer pain patients. Cancer pain, according to its pathogenesis, as we know, it could be nociceptive pain, neuropathic pain, or mixed nociceptive and neuropathic pain. In next slide, we will show video demonstrate the nociceptive and neuropathic for cancer.
Pain can also be classified as nociceptive or neuropathic. In general, nociceptive pain arises from the stimulation of pain receptors called nociceptors when body tissues are damaged. It is often described as cramping, aching, throbbing, or dull pain. Neuropathic pain occurs when nerve pathways are damaged or function abnormally. It can occur independently of nociceptive pain or in conjunction with it. Neuropathic pain is usually described as sharp, tingling, or burning, and often radiates. It is frequently difficult to treat.
So it's very important to know the cause and the type of pain. Understanding cause of pain is very important. As we said, it could be directly caused by cancer and could be cancer treatment cause or non-cancer another disease. Understanding like causes, mechanisms, and the pain type is the key to appropriate management for the cancer pain. We have also to consider upon metastasis pain as primary tumors in breast or prostate or lung are the most frequently associated with bone metastasis. Common sites could be vertebra, pelvis, femur, and skull. The pain is caused by local bone destruction, as we see here, and causation of pathological fractures, infiltration of surrounding tissue, secondary muscle spasm, or compression of neurological structure. Breakthrough pain, it's also another consideration we should also consider, because we have all background pain and breakthrough pain. Breakthrough pain is a transient exacerbation of pain that occurs despite adequate control of background pain. So when we describe the by the clock, the management for cancer pain by the clock, it's for covering the background pain. Also, we have a breakthrough pain. It's a sudden onset with short duration, and it's severe or excruciating pain. It reaches a peak within minutes after onset and lasts on average 30 minutes. So it's not enough to cover it by the clock medication. So as we should give a short acting opioid medications. Characteristics of cancer pain due to bone metastasis, as we said, it could be background and breakthrough pain. Successful treatment of cancer-induced bone pain is challenging management, and nearly half of all of the patients reports poor pain control. The privilege of breakthrough pain is somatic 33% to 46%, visceral pain 20 to 30%, and the mixed pain is 60 to 20%, neuropathic pain 10 to 35%. Oral opioids are commonly used to manage breakthrough pain. However, current evidence suggests that buccal, sublingual, and nasal transmucosal fentanyl may be a more appropriate choice of treatment for breakthrough pain. Comprehensive assessment of cancer pains, it's from NCCN guidelines 2020. It's as pain diagnosis as etiology and pathophysiology, because etiology is associated with cancer as a cause or cancer treatment, or coincidental and related to cancer, or as a pathophysiology, nociceptive neuropathic mixed pain. So as chronic pain, the same assessment we do for cancer pain. For chronic pain as the cancer pain, the differentiate between cancer pain assessment, because the cancer, it's progressive all the time, so it gives us an indicator if the pain is severe, that the tumor, it's metastasis to another area, or a tumor progression, so it's an indicator for severity of pain. Effective management of cancer pain, it's interdisciplinary. In 2020 NCCN guidelines updates, they changed from multidisciplinary to interdisciplinary. Interdisciplinary means that they should meeting in one area, like pain specialists take a lead role in managing patients with cancer which no longer treatable. General practitioners are involved at many stages of care for cancer patients. Pain is an important aspect of multitude of problems that oncologists are facing, and palliative care doctors also. Pain management, the goal of treating cancer pain is achieve pain relief and assure the highest possible quality of life. There are multidisciplinary, interdisciplinary approach in cancer pain treatment, including causotherapy, pharmacotherapy, nerve blocks, electrostimulation, neuroablation, physiotherapy, psychotherapy, acupuncture, and physiotherapy. Today, my talk focusing on pharmacological cancer pain management. So, criteria for selecting an analgesic, although type of pain is important, as we said, other factors should also be considered. The interaction with other analgesic, intensity of pain, comorbidities, side effect, cost, abuse, potential culture influence. So, which opioid we can give or prescribe for this type of patient is challenging. It should be thinking about that. So pharmacological management mechanism-based approach, as we said, is according to underlying pathology or mechanism of pain in the individual patient. Yes. So it could be for visceral pain, opioid and plus non-steroidal for visceral pain, soft tissue inflammation, bones pain, muscle spasm, we give muscle relaxant, and opioid plus corticosteroids for neural compression, opioids, tricyclic and antidepressants, anticonvulsants, neuroleptic for neural injury. This is, we have WHO ladder, 3 WHO, the principle governing the use of analgesic and adjuvants. It's summarized in WHO ladder, 3 ladders. So first ladder is non-opioid, it's plus minus adjuvant, plus minus non-opioids. If pain persisting or increasing, we go to the second ladder. It's weak opioids plus for mild to moderate pain, plus minus non-opioid or plus minus adjuvant therapy. If the pain persisting or increasing, we go to the next ladder, third ladder, strong opioids for moderate to severe pain. It's plus minus non-opioid, plus minus adjuvant. The fourth ladder, it will be invasive therapy or interventional until we get a freedom from pain. So this EPIC guidance, it's by the mouth and by the clock, by the ladder. So by the mouth, it should be first, always we should start from orally prescription drugs. By the clock, we have to cover by the clock as a regular, not PRN. It's just as regular to cover the background pain. And by the ladder, we as we said, it's 3 ladder WHO, we step by step. Morphine preferred, this is the preferred strong opioid. So always we start with morphine orally. Methadone not recommended for non-specialists because of methadone. It's difficult to titrate methadone, and the patient should be in inpatient and in close observation. This is the new guidelines. It's NCCN guidelines 2020 published in April. Most of slides I took from WHO guidelines and protocols and NCCN guidelines. This is opioid analgesic opioids, weak opioids and strong opioids. Weak opioid like codeine, tramadol, strong opioids like morphine, buprenorphine, oxycodone, fentanyl, tapentadol. Tapentadol, it's mixed mechanism of action, mu opioid receptor plus neuroadrenaline reuptake inhibitors. Opioids are mainly effective in managing nociceptive pain, are partially effective in relieving neuropathic pain, are the mainstay analgesic for pain associated with cancer. So opioid analgesic, weak opioid like tramadol, we know the mechanism of action, mu opioid receptor agonist. It's we start the dose with 25 to 50 milligram Q4 to 6 hours, immediate release, 50 to 100 milligram Q12 hours CR or controlled release. Codeine also act on mu opioid receptor agonist. We start the dose from 30 milligram Q4 to 6 hours immediate release, 60 milligram Q12 hours controlled release. Also, we have to consider the side effects for tramadol, like nausea should be prevented by antiemetics. Antiemetics, it always the nausea and vomiting, it should be tolerated 48 hours after the pain. So we give also the antiemetic as a PRN, not regular. Constipation should be prevented by laxatives because constipation, there is no toleration and adaptation. So we have to prescribe laxatives as a regular, should be for when we prescribe codeine or opioids. Morphine, it also acts on mu receptors agonist. We should start always from 5 to 10 milligram Q4 hours immediate release, 20 to 30 milligram Q12 hours as controlled release. Fentanyl, mu opioid receptor action, also based on patients' current opioid use. One patch, we put like 20 or 25, 50 or 75 or 100, every 12 hours. It's every 3 days, 72 hours. Methadone, it's an MDA and mu and opioid receptor agonist. It's mixed action, and the dose we start 3 to 5 milligram Q8 hours. Oxycodone, also it's acts on mu and kappa opioid receptor agonist. We start the dose from 5 milligram Q4 to 6 hours immediate release, 10 to 20 milligram Q12 hours controlled release. Tabentadol, we start from dose 50 milligram Q4 to 6 hours immediate release, 100 milligram Q12 hours controlled release. This is strong opioids. This is the morphine, prolonged half-life in renal failure. Also, we have fentanyl patch. As we said, it's 5 types of fentanyl patch, 12, 25, 50, 75, 100 microgram per hour. Oxycodone, it's also a strong opioid. It has very similar properties like morphine. Most commonly used as a second-line strong opioid when morphine is contraindicated or not tolerated. More potent than morphine. The recommendation to have the dose of oral morphine when converting to oxycodone. So opioid switching. When we do opioid switching, it's like to improve the level of pain relief to reduce problematic side effects. So if we have like side effects from a strong opioid and we want to switch to another opioid, first we have to manage the current side effects. Then we reduce the dose of the current opioid. Then we can switch to another strong opioid. This is a table of opioid conversion for oral and transdermal medication. Morphine is like standard. If we want to convert from a strong opioid to another, always we have to refer first to morphine. Then for a time, then we transfer to another strong opioid. This is morphine to buprenorphine 100 to 1, morphine to tramadol 1 to 5, morphine to fentanyl 100 to 1 is the relation. Recommendation: reduce by calculated dose by 30% and provide breakthrough medication, as we said. For example, here, how to use opioids for cancer pain management is from a protocol, WHO protocol. How to start a patient on oral morphine: start with immediate release morphine Q4 hours and instruct the patient to take extra dose, that is 10% of the 24 hours total dose. Q1 hour as needed. Morphine reached peak plasma concentration. It's about 60 to 90 minutes after oral admission. What's the right dose to start? The appropriate starting dose of oral, always we start oral immediate release. Morphine depends on many factors like age, body weight, renal and liver status, and degree of the pain. So the dose for adults more than 60 kilogram weight is 5 to 10 milligram, as we said. In all cases, after initiating pain management, follow specialty service consultation guidelines, as we said in WHO protocol and NCCN guidelines. Switching the routes of administration when you want to convert the patient from oral morphine to parenteral morphine, calculate the 24 total intakes of morphine and divide it by 3. Then give this amount over 24 hours. If you want to convert from parenteral to oral morphine, the daily dose is multiplied by 3, and the amount will be given as 2 to 3 divided dose. Opioids in patients with organ dysfunction like liver cirrhosis, renal failure, or liver failure. Morphine, hydromorphone, methadone, levofloxacin, buprenorphine, it's safe for liver cirrhosis. We can give for renal failure, safest methadone, fentanyl, buprenorphine. Moderate safe, oxycodone, hydromorphone. Least safe, it's morphine. It has a prolonged half-life in renal failure patients. Liver failure, methadone, and buprenorphine is safe. Special consideration in elderly cancer patient with pain. It's pain in elderly patient may be undertreated due to less compliance about pain, concomitant illness, treatment with multiple medication, inability to tolerate opioids. The practical recommendation on the use of opioid in elderly cancer patients, like this is the recommendation: select least invasive route, use long-acting or sustained release preparation around the clock for continuous pain, prescribe one drug at a time, begin with low doses, increasing slowly, use drugs with a short duration of action to avoid the side effects of opioids for elderly patients. When changing opioid, decrease equi-analgesic dose by 50% because of incomplete crossover. So always when we want to change opioid or switch, always we decrease the equi-analgesic dose by 50%, then we change. Be aware of additive effects. Continue the drug for adequate duration. Opioid-induced side effects, common side effects, nausea and vomiting. As we said, it's tolerable within 48 hours, and so you have to give PRN and PRN antiemetics. Constipation, it's not tolerable, so you have to give regular laxatives drugs. Increased risk of respiratory depression also is side effects of opioid, so we can reverse it with naloxone. Sedative or hypnotic effects, hypertension, also a decreased heart rate, meiosis, cholestasis and micturition disorder, urticaria, pruritus. It's a rare side effect, but we cannot reverse it with naloxone because it's not H1 antihistamine mediated factor. So we have to change or switch the opioid to another opioid. Adjuvant medication. A primary indication for adjuvant medication is not pain, it's mixed cancer pain, it's for purely neuropathic cancer pain, metastatic bone pain, chemotherapy-related pain. As we said, the opioids, it's not effective as much as we need for neuropathic pain, so that's why we have to give mixed with adjuvant medication. Adjuvant medication like antidepressants, anticonvulsants, topical agents, corticosteroids, and NMDA antagonists like ketamine, relaxant. Co-analgesic in cancer pain, antidepressants for treatment of its first-line treatment for neuropathic pain. Side effects, it could be anticholinergic effects like nausea, dizziness, and bisphosphonates treatment of osteolytic bone pain. So bone pain, as we said, it's challenging bone pain control. So we prescribe bisphosphonates for bone pain. Side effects could be pain flare, osteonecrosis, ketamine for unrelieved neuropathic pain. So this, so ketamine we give in case of we don't, the patient doesn't respond to opioids, doesn't respond to adjuvant like antidepressants or anti-epileptics. We prescribe ketamine. We have to aware about side effects like hallucination. Lidocaine plaster, it's a lidocaine patch, treatment for of localized neuropathic pain that's caused by cancer. Local skin reaction is the most common side effects of lidocaine patch. Corticosteroids, treatment of neuropathic pain. Corticosteroids, the most common we use dexamethasone as anti-inflammatory. They have more anti-inflammatory effect and less mineral corticoid effect than the prednisolone. So we use dexamethasone more. The side effects could be steroid psychosis, anticonvulsants. This is treatment of neuropathic pains. Also, second line treatment if the patient cannot tolerate antidepressant, we have to convert to anticonvulsant, or if the patient doesn't respond to anticonvulsant, we can give together antidepressant plus anticonvulsant. Also, we have to be aware about side effects of anticonvulsants like dizziness, sedation. So antidepressants compared to anti-analgesic effects, it's lower dose plus earlier onset of analgesic use than antidepressant activity. So need lower dose to get analgesic effectiveness. So antidepressant like tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors. The most common use amitriptyline, imipramine, and the serotonin SNRI, duloxetine, venlafaxine. Antidepressants, we have like a red flag here. It's a red flag for congestive heart failure, ischemic heart disease, cardiac arrhythmias. Yellow flag for glaucoma, sedation, anticholinergic effects, and green flag for gradually titrates and taper every 5 to 7 days, because it takes 5 to 7 days until it works. If it doesn't work, we have to titrate the antidepressant every 7 days if the pain is increased or still. Imipramine is TCS, like was it could be 10 milligram, 25 milligram, very slow onset, difficult to titrate. SNRI, like duloxetine, trade name Cymbalta, venlafaxine, it's also common. Duloxetine 20-30 milligram per day, maximum 60 to 120 milligram per day. Venlafaxine 37.5 milligram per day, up to 75 to 225 milligram per day. Anticonvulsants, it decreased the NRS to 48%. Frequently used with an opioid for the neuropathic component of pain. Gabapentin and pregabalin, the most common use anticonvulsant. Other like lamotrigine, levodopa, no effects on cancer pain. Anticonvulsants also we used before as anti-epileptic, classical anticonvulsants, gabapentinoids, benzodiazepines. We have yellow flag dosing monitoring predicted pharmacokines, so we have to calculate, and we have to be aware about withdrawal syndrome. Side effects of gabapentinoids, and green flag for anxiolytic effects of benzodiazepines. Gabapentinoids like gabapentin, the trade name neurotonin, 300 milligrams. It's 100 to starting dose 100 to 300 milligram daily, up to like 1,200 milligram in 2 or 3 divided dose, used in post-herpetic neuralgia and neuropathic pain. Pregabalin, Laricat's trade name, 75 milligram per day. It's, we can use 25 milligram just prior to sleep, PID or triple in a day. For post-herpetic neuralgia, we increase the dose to 600 milligram. For we can use also for fibromyalgia, dose 450 milligram. For also diabetic polyneuropathy, we use the dose 300 milligram. Topical agent like lidocaine patch, apply up to 3 patches typically at a time for up to 12 hours within a 24-hour period. We use for cancer-related neuropathic pain, for post-herpetic neuralgia. Corticosteroid, as we said, the dexamethasone, the most common we use, 1 to 2 milligram oral PID. The corticosteroid, it's as we said, it's has the most anti-inflammatory effect comparing with other corticosteroids like prednisolone or hydrocortisone, and less mineral corticoid effect. Breakthrough pain, as we said, this background pain and around the clock pain. Breakthrough pain treatment with strong opioids. Here it's management, morphine 1 to 10 to 6 of the total background morphine daily dose. Route of administration, it's oral immediate release tablets and drops. Buprenorphine dose for breakthrough pain, just between 0.2 to 0.4 milligram. Route of administration, sublingual, subcutaneous. Fentanyl, oral transmucosal, can also give, and transmucosal and transdermal can we give because of highly lipophilic effect characteristic. Oral transmucosal 200 to 1,600 microgram, sublingual 100 to 1,600 microgram, and intranasal also we can give fentanyl. Dose of hydromorphone between 1.3 to 2.6 milligram. Route of administration, oral immediate release tablets, and IV we can give also. Opioids for cancer pain. Also, we said like we have to cover background pain and breakthrough pain. Background pain, we have to use morphine or Amaxel, fentanyl patch, oxycodone, hydromorphone. For breakthrough pain, we use Fentora. It's fentanyl focal tablet, fentanyl film painkiller. Morphine solution Q4 hours. Also, we can use oxycodone as oxynorm Q6 hours. This is the Fentora. As we said here, it's fentanyl focal tablets. We give Q4 hours. Fentanyl focal tablets. This is how we put the patient bends and pills blister packing to expose tablets. Patient immediate places focally, and we can give how to take. This is how to take Fentora focal and sublingual. And thank you very much. Dr. Ammar.
Thank you very much, Dr. Abdullah, for this amazing
Excellent
presentation.
Excellent talk, Abdullah. Overview, nice overview. Very good.
Thank you very much.
Very good. So, the Moroccan Pain Academy is a young society and a young group which we support very much. We're supporting our friends from the Western region, from Morocco, Algeria, Tunisia. The Algerian pain society is very active. We noticed that. and we'd like Dr. Ahmed Al-Omri to continue on this. And we are here to always support you, and we'll be behind you till you succeed in spreading the knowledge about pain management in our region and your region. Any questions? We can see here in the chat box some questions. Did you, waiting for questions, did you use buprenorphine high doses, Abdullah, in your practice? Because the doses that, the doses that are used for acute pain are low dose, like 5, 10, and 20 mics, while for cancer, it's 400 mics in a small patch, which delivers the medication in 7 days. So do you have the chance to use it in cancer patients?
Well, we don't use buprenorphine patch in Taiwan because we don't have, but we can use,
What do you think about breakthrough pain? Can you elaborate on breakthrough pain? What are your options for breakthrough pain?
We use here for breakthrough pain, most common Fentora and Painkill for breakthrough pain.
So the nasal fentanyl.
Yeah.
Okay. Do you use the sublingual fentanyl?
Sublingual also fentanyl. We use it. We use sublingual. We use intranasal. So as you know, for breakthrough pain and cancer pain, it's like a clinical trials cancer pain. So we try and titrate the pain. We start always for breakthrough pain short acting and rapid onset opioid when we choose the medication.
Great. Perfect. Any questions from the panel here?
Yes, thank you. Thank you. Yes, I have some question. Thank you, Dr. Ammar, for your support and your kindness. And thank you, Dr. Abdullah, for this wonderful talk. It was very, very interesting talk. Excellent. And I have some question about ketamine. When do you use ketamine in your practice? You use it in acute pain or in second line?
Yes, ketamine. We use it, as we said, when we don't response to the opioid, or we don't have response to adjuvants like antiepileptic or antidepressants. We can start use ketamine, but ketamine has restrictions. We don't use it as first line treatment because of side effects, as we know, hallucination.
Okay. Now about effusion of lidocaine effusion.
Yeah, we use it effusion lidocaine sometimes in acute pain. But more common we use in Taiwan fentanyl infusion or not infusion, or we use like PCA or PC for acute pain.
Okay.
Perfect. We have got one question here for Dr. Abdullah, coming from Dr. Kwang Hong. He has a patient with chest wall pain due to lung cancer metastasis, not responding to oral medications. What should I do now?
Not responding, intervention. Not responding for oral medication, we go to the fourth ladder. As we said, it's intervention.
So what would you do for chest pain due to metastasis? Chest wall pain.
Yeah, chest wall pain. We can do like stellate ganglion or interscalene. It depends where is the pain exactly.
On the chest.
On the chest. We do a stellate ganglion.
A stellate ganglion is sympathetic block. It's not going to help with nociceptive inflammatory pain. It can be an adjuvant as a stellate ganglion block, but do you do like, for example, intercostals, erectrospinae, paravertebrals?
If it's a neuropathic pain, we do intercostal block, yeah.
Yeah, it's metastasis in the chest wall pain. probably irritation of intercostals. So probably it's good to combine. Good to combine. Good. T8 and T11 on the left side. This is exactly where the pain is.
Yes.
So T8 till T11 on the left chest wall.
What again?
The pain is localized on the dermatome of T8 to T11 on the left side.
We do the DRG, DRG-PRF for the same dermatome, T11, T9 for the same dermatome.
So pulse radiofrequency of DRG.
Pulse radiofrequency for DRG, yes.
Okay. Jane Perez, she's saying good morning. She must be from the Latin America. Your experience with intrathecal pumps with opioids in patients with oncology pain. She's from El Salvador. Welcome to Jim from El Salvador, and welcome to our friends from Latin America. She said that the cost of intrathecal pump is very high in El Salvador. How do you manage this pain in cancer patients, palliative patients, without having the chance to have intrathecal pumps?
So as we said, it depends of localization, it depends of the mechanism and pathogenesis. If it doesn't respond to oral medications or adjuvants, then we move to another nerve blocks or radiofrequency ablation, or then if we cannot do intrathecal pump or injections.
Perfect. Any other questions from the panel?
Yes, Dr. Am.
Yes, please.
Yes, I have only a comment.
Yes.
Because cancer pain is a dynamic condition, because cancer pathology is dynamic also. So we should, at every change of pain intensity, of pain characteristic, to look for any etiology. Sometimes some patients are sent to pain physician because of pain, but the oncologist check everything and there is no cancer recurrence or metastasis or other condition. So that sometimes we consider patient that has a chronic post-surgical pain without cancer recurrence. And here I want to emphasize the interest of preventing this post-surgical pain, because as anesthesiologists have a lot to do, many strategies to do to prevent post-surgical pain and then to minimize the patient suffering, like opioid-free anesthesia, nerve blocks, and better management for acute post-operative pain. Yes, thank you.
Yes, very, very valid point and very important comment. Post-surgical chronic pain is something very difficult to tackle. We know that it can go up to 50-60% after some surgeries like thoracic surgery or breast surgery. So we need to think proactively and prevent the occurrence of pain for these patients. I agree 100%. For the prevention of chronic post-surgical pain, it's something very, very, very useful nowadays, is to combine adjuvants. We were talking about ketamine. The anti-NMDA effect of the ketamine is one of the good options. The alpha-2 agonist like dexmedetomidine or clonidine in combination is also a good option. Just I wanted to comment regarding Dr. Ahmed's question regarding the ketamine, acute or chronic. For patients who are going for cancer surgery, for example, the evidence is very strong regarding combining ketamine and morphine for PCA, for example. In the same syringe, there is a ratio of 1 to 3, 1 milligram of morphine, 3 milligram of ketamine in the same syringe in order to have very good efficacy of the narcotics, the morphine in this case, and add on the anti-NMDA receptors to reduce the liberation of all the mediators from the tumor itself. So it's very interesting combination that is with very high evidence that can be very helpful also to anticipate and to prevent chronic pain, post-surgical chronic pain.
Okay, thank you. Thank you very much.
Okay, if there's no other questions, I have the pleasure to introduce our second speaker, and the agenda is very well designed, actually. We started with pharmacological, now we would like to hear about the non-pharmacological, and one of the key messages from Dr. Abdullah's lecture is the multidisciplinary approach. And this multidisciplinary approach will lead us to talk about non-pharmacological options for the treatment of cancer. Please, Dr. Ahmed.
Thank you, Dr. Ammar, for introduction. Can I share, Dr. Abdullah, if you can cancel your share?
Yes.
Screen. Thank you. Not yet.
From the top, Abdullah, you have a button. Stop sharing. Yes,
that's good. That's good.
Thank you.
Thank you. It's good now?
Yes, perfect. You can see it.
Perfect.
Go ahead. Yeah.
Okay. Thank you very much for the introduction, and we'll talk about non-pharmacological strategies in cancer-related pain. And we'll start with the pain, the cancer pain, and the definition of pain. As you know, is an unpleasant sensory and emotional experience was associated with actual or potential tissues damage or description in terms of such damage. About pain, there is 4 dimension, or the pain is multidimensional symptom with 4 dimension. The first dimension is sensory discriminatory dimension, emotional dimension, cognitive and behavior dimension. And when we need to treat pain, we need to have in our mind this 4 dimension, and in cancer pain is very, very important to integrate this 4 dimension in our management of cancer pain. Physical and psychological complications is very important in cancer diseases and cancer pain, and with great and with impact in quality of life and societal impact, very, very high societal impact in cancer pain. The multidimensional models of chronic pain related to cancer, we have this 4 dimension, the sensory discriminatory dimension with the duration, localization, type, intensity, pain, neuropathic pain, nociceptive pain. The emotional dimension is the complication, or how this pain lead the patient to anxiety or depression. Have the symptom is very, very frequent in this side. The cognitive dimension have anticipation, attention, diverting attention, interpretation, and significance of pain. It different. It's the signification is different between, for example, between 2 patients with the same disease, with the same, for example, localization, but the interpretation and significance the pain is different. It's different from the person. Is different of between country, between ethnicity, between male or female, and the reference to past experience is very important to define. The decision regarding pain behavior is very important to know. We have to know this, and we have assessments of the cognitive or emotional pain, and the management of pain would be leading with these assessments. The fourth dimension is the behavioral dimension with intervention of environmental or cultural, ethnocultural, and family influence, the past learning, for example, of diseases or of pain, and the psycho-environmental factor. For example, this is the difference between pain-related cancer with a patient in low or low-income country, and with the same patient, for example, in developed country. This is the influence of environmental factor. And how do we have, for example, chronic cancer pain related to repeated inadequate management of the vicious circle? As you see here, when, for example, have an repeated inadequate management of pain, the problem we will have deconditioning, and after we can have increase of pain perception, decrease in daily activity and impact of quality of life, depression, anxiety, and distress, anger or anxiety. Have this vicious circle of chronic cancer pain, and the decay of disturbing this vicious circle is to have an adequate multimodal personalized management for having a controlled cancer pain. As you see, we can't have a controlled cancer pain just by administration, medication, or intervention. We need to treat all this dimension, and we need to integrate all this dimension for treating or for having a good management of cancer pain. What is the barriers to pain management for cancer pain? For example, we have 3 levels of barriers: provider barriers, patient and family barriers, and system barriers. Provider barriers is the lack of awareness, for example, of patient pain, inadequate cancer pain management training and education, the lack of time and resource to address cancer pain. And we have all these barriers in our practice in our country. For example, we have a high priority to cure rather than treating patients for symptoms. And the other problem is legal and regulation sanction for opioid use in some countries. The second level is the family and the patient barriers. And what believe that patient is inevitable in cancer is many patients that believe in this cancer lead to pain and is inevitable. Nothing can be done for cancer pain, and this is a belief of many patients, but not just many patients, but this belief of many practitioners. And we need to make informative and to make a lot of informative session for patients and for practitioner, health practitioner, about cancer pain, and that we can do something for cancer pain, and we can control this cancer pain. The addiction and dependence on opioids, this is patient barriers and family barriers. The fair drugs with loss of effectiveness, opioid effectiveness, for example, and have the mention of pain to the providers and lack of adherence to treatment regimens, high cost of medication and treatment, and cognitive impairments hiding symptoms assessment. But with cognitive impairments hindering the symptom assessment, we have now some assessment for example, for patients with cognitive impairment. We can use these tools and this assessment for evaluate the pain. The system barriers, we can have the lack of communication between practitioner and primary care providers, lack of coordination of care during transition from cure to palliative care to hospice mode, and priority or curing cancer over caring for patients with cancer. The other barrier system is a lack of reimbursement for symptom management and the regulatory barriers to effective pain management. And as you see, we have a level of barriers. We have a lot of barriers for pain management to cancer pain, and we can have this vicious circle that we have non-pain controlled. And here we have the four-dimensional pain with sensory discriminatory, emotional, behavior, and cognitive dimension. As you see here, we can start with education and communication. It's very important to educate our patient about cancer pain, about all the techniques and all the procedures about cancer pain. For behavior, cognitive dimension, we have cognitive behavior therapy. For behavioral dimension, mindfulness meditation is very important. For emotional dimension, we can support this patient with mind-body practice, mindfulness meditation, relaxation, hypnosis, and virtual reality, or we can now use virtual reality in therapy for this patient. In sensory discriminatory dimension, we can use dance or electrotherapy, acupuncture, mind-body practice, physical therapy, or physical activity. And all this complementary integrative approach, this is a multimodal cancer pain approach. We can use it with the other medication, for example, with pharmacological treatment, or with the intervention, or in prevention of cancer pain in adjuvant with other treatments. I can start with the evidence-based non-pharmacologic therapy for cancer pain. We start with acupuncture as evidence-based non-pharmacologic therapy. This is a safe procedure. It's delivered from Chinese medicine, and have in clinical practice guidelines make the acupuncture as grade C recommendation for using in this acupuncture, this procedure to treating pain in cancer patients. The American Society of Clinical Oncology clinical practice guidelines say that acupuncture was effective in improving pain, but the evidence quality is low and the strength of recommendation is weak. We need more paper, more manuscripts, and more study for having a good evidence quality. But the advantage is that we can use the acupuncture in the side effect of radiation treatment, for example. There is many study about use of acupuncture in side effects of radiation, including pain associated with dysphagia. We have a good result with acupuncture. We use peripheral neuropathy, peripheral nerve neuropathy induced by chemotherapy. We can use acupuncture as adjuvant treatment, for example, with other medication, gabapentin or anticonvulsants, and we have to use acupuncture. There's many studies that say that this therapy may be useful in adjuvant with other pharmacological therapy. How about electrical nerve stimulation? Electrical nerve stimulation is useful in neuropathic pain, but in cancer pain, there is a transfer efficacy of they're reported in patients with neuropathic or mixed pain, but we don't have evidence-based studies or review that say that electrical nerve stimulation, only electrical nerve stimulation can be used in neuropathic pain in with the person suffering of cancer pain. But this is a good way to treat neuropathic pain at home with delivering to patient electrical nerve stimulation within 30 between 20 and 30 minutes and once or 2 times a day. It's a good alternative in supporting or palliative care for neuropathic or mixed pain. The physical exercise, including community exercise program, resistance training, walking, cycling, stretching, or strength training, this physical exercise has been associated with improved psychological and behavioral and physical condition in cancer in cancer patients with cancer pain. There's a higher level of physical activity are associated with lower pain levels. But the efficacy is progressive resistance exercise training has been demonstration in shoulder pain and disability and upper extremity muscular strength and endurance in head and neck cancer survivor. But the treatment related this activity is bias often need to be removed, and the physical exercise must be tolerated to obtain appropriate duration and intensity. We can't, for example, propose cycling or intensive physical exercise to the patient with, for example, frequency or upgrade grade of cancer pain, for example. We need to personalize this physical exercise. We need this exercise need to be tolerated to obtain the appropriate duration and intensity, and each exercise, each sport to do with cancer pain. I mean, as you know, the problem with physical exercise is the intensity and duration. For example, this is many studies that showed about under 1 hour and 30 minutes, the physical exercise is not good, for example, for the patient with cancer pain. We need to have fraction of exercise with a good duration, less than 1 hour, for example, in each time of exercise with resistance tolerated by patients. How about physical therapy? The offer of the various application of physical therapy, multifactorial physical therapy, and active exercise are effective for treating post-operative pain. For example, breast cancer treatment and impairment of range of motion. But no such results have been obtained with passive mobilization, stretching, or myofascial therapy as parts of this multifactorial treatments. But for physical therapy, the massage therapy is very, very important, and have a systematic reviews and with meta-analysis for describing the effectiveness for patient in cancer pain compared to active comparator or usual care. What we have as a result, we have that massage therapy was also effective for metastatic bone pain or pain in children with cancer and pain with children and those undergoing stem cell transplantation. Have a good evidence-based result for massage therapy in physical therapy. The mind-body directed therapy is very, very useful in cancer pain as non-pharmacological therapy. And we can use mindfulness-based course, including web-based mindfulness intervention. This intervention is supporting cancer patients' symptom. In systemic review, we described that in meta-analysis, mindfulness-based stress reduction had a beneficial psychological impact for breast cancer patients. And we have a good impact in quality of life, mood, and distress with these patients. A recent trial for this mindfulness-based stress reduction for metastatic breast cancer patients demonstrated that we have a positive impact on distress with a mild effect of improving average of pain. This therapy is very useful, and we need to introduce in our practice this mind-body directed therapy in the management of pain. The other side of the management of pain or this behavior therapy is the music therapy. And in the last years, we have some paper, some manuscripts, and in the large systematic review with meta-analysis, musicotherapy and music therapy showed statistically significant improvements in cancer pain and in emotional distress, as we see in our first slide, that we have 4 dimensions of cancer pain of this is emotional dimension, and behavioral dimension is very important. And music therapy is good to statistically significant improvements with this dimension, emotional distress from pain, but we have a small significant effects on anesthetic use. But this is a significant effect, small, but it exists. Opioid and not opioid intake. The music therapy is in palliative care setting found significant improvement in pain, anxiety, depression, and shortness of breath and mood. And now in many units of management of pain units, we introduce the music therapy in the treatment as a good treatment or a good alternative for in palliative care. And we have to access our music therapy in how to make emotional distress with this music therapy. It's very important to introduce that. The hypnosis, and during the treatment period, have a beneficial effect of hypnosis on cancer-related pain relief. In the treatment procedures, concomitant disease like mucositis, in addition to X activity against distress or anxiety, we use hypnosis. For example, before starting the procedures or for patients in our practice, we have to use that as alternative for many patients. The efficacy of hypnosis is well established, and as you see, we have to advanced breast cancer. We have reported highly hypnosis patients, and we have great results and great benefit on pain relief related. Thank you very much. As you see, we have a lot of procedures, a lot of non-pharmacological strategies with good evidence-based studies, but we need to introduce these strategies in our practice, or to introduce some of these strategies in our practice in the management of cancer pain. Thank you very much.
Perfect. Well done, Dr. Ahmed. Very nice overview about non-pharmacological treatment. It's a very important topic, and you summarized it very well. It's amazing how you made it easy for everyone.
Thank you.
It's not an easy task. Very good. Any questions from the panel before looking at the chat box? I have one question. How do you quantify the importance of this method compared to pharmacological in percentage, for example? Do you think that it has 10%, 20%, or 50% involvement with the strategies in cancer patients?
I think for the strategy in cancer patient, we need to introduce this strategies, non-pharmacological strategies, with the pharmacological strategies. It's very important because, as you see in the fourth, we have 4 dimensions of pain, and with pharmacological or intervention procedures, we treat just 1 dimension, and we need also to introduce this dimension. In my mind, is very important, and it may help us to have a good results with pharmacological or intervention procedures. It will be between 30 and 40% in our practice, because we have to try to communicate more with the patient, and it will help us for making this communication and for starting good pain management with pharmacological, for example, treatment.
Perfect. Any other questions? In Taiwan, for example, do you have music therapy for cancer patients?
No music therapy. No music therapy.
So you don't understand it. You're not. Yeah.
So what do you think, Professor Ahmed Amin, the optimum time to start non-pharmacological approach? So related together with pharmacological, or what?
With or before, because we for example, hypnosis or mindful, for example, therapy we can start before starting, or in concomitant with starting our pharmacological practice.
That's good. Yes, Dr. Osama, please.
Professor Ammar, I think this music therapy, it's French school, right?
It's international school.
International, yes.
Dr. Osama, you wanted to comment?
Thank you. I have a question for my friend, Professor Ahmed Amin. I was thinking about manual osteopathy. So we practiced it a lot of years. What do you think about osteopathy in the pain cancer? Is it?
Yes, it's very good question. That we practice chiropractic or osteopathic techniques in chronic pain. For example, I have some papers, some manuscripts that show that chiropractic or osteopathic technique can be useful in some pain, some chronic pain. But the problem in cancer pain, we don't have enough reviews about that. That's why I doesn't make it in my lecture. We need to have more study about chiropractic, but we can use, for example, osteopathic technique for this patient, but not with. They can have, for example, low back pain or cervical pain, but we mustn't have, for example, bone metastasis, and it's very, very difficult to say to our patients that we can use a technique, but we don't know, we don't have, for example, some evidence, and we have a risk, a higher risk. If you have, for example, bone metastasis and you do this technique, we will have not good surprises, and that's why we need to have more study and more evidence about this technique.
Yes. Can use
Great. Yes.
non-manipulative technique.
Yes. Yes, we can use non-manipulative. I make it in physical therapy. That's non-manipulative technique, but for manipulation, for vertebral manipulation, in my mind, we haven't to use that.
Yeah.
Dr. Mustafa, any comment?
Yes, I have also a comment. I think these non-pharmacologic treatments are very important in treatment of the patient, not only as a palliative care, because we are seen by the oncologists that maybe it's only palliative care, only end of life support for patients. But this non-pharmacologic and also pharmacologic treatment for cancer pain, it can involve the patient treatment, cancer treatment, and the overall life treatment of the cancer, because some patients have a lot of pain and they can abandon treatment of cancer. And this pharmacological treatment and non-pharmacologic treatment can distract the patient and encourage him to continue the cancer treatment.
Yes, it's an adjuvant. Yes, absolutely. Perfect. I think we have, let me see if you have some questions. Nothing. Role of ultrasound-guided celiac plexus block in relief pain. This is a question for Dr. Abdullah Kharabshe.
Yes.
Any ultrasound-guided celiac plexus block?
Celiac plexus block, actually in Taiwan, we do splanchnic nerve block, but celiac plexus block, if the patient cannot move and you want to do anterior approach, you can do ultrasound guided. It helps. Mm-hmm. But now, because splanchnic, it's more safe than celiac plexus block, all of our cancer pancreatic cancer pain, we do bilateral splanchnic nerve block, plexus block, plus pulse radio frequency.
Mm-hmm. The effect of hearing Quran to relieve cancer pain, Dr. Ahmed?
Yes, in our countries or in our practice. Yes, this is important of hearing Quran this is many articles of important in religion, for example, in many religion. This is important in the dimension of behavior, emotional, and anticipation on all this. This dimension, we have this impact of religion in our patients. It is very important. For example, in our in a lot of lot of arthritis, this is very important to have this, for example, recognize of impacts of emotional impacts, for example, or good impacts of religion in the perception of cancer, the perception of pain-related cancer. We have many papers about that, and it's all about the perception of pain or an intervention of perception of pain or anticipation pain.
The concept of mind over body.
Yes, mind over body, yes.
Great. I think we had a very nice overview on this topic. And now we'll go to our experts in musculoskeletal issues. And I like the title of his lecture, Cancer or Malignancy Related to Autoimmune Musculoskeletal Disorders. I'm very keen to learn from him about this topic. Please, Dr. Abdullah Alam from Tanta University. He's very expert and very active in MSK, pathologies, and ultrasound mainly. He was invited many times to EULAR workshops, and he's done also some of training in the same university as Abdullah Kharabshi in Taiwan. Please, Dr. Abdullah, floor is yours.
Thank you very much, Professor Ammar Salti, for your nice introduction. Thank you for...
Raise your voice, my friend.
Thank you for Professor Ahmed Amin, and thank you for Professor Ammar Salti for introducing me to present such important topic in today's webinar. And I will talk about malignancies and the painful autoimmune rheumatic diseases. My talk is to raise the awareness about the crossroads between malignancy and the rheumatic diseases, and the rheumatic diseases can lead to development of many types of cancer, and also various types of malignancies can present with rheumatic disease, which is called a paraneoplastic syndrome. And in my talk, I will talk also about the metastatic bony pain and how to treat, and the section of the treatment. Regarding the crossroads between malignancies and rheumatic diseases, the genetic background plays an important role in development of malignancies, some malignancies in autoimmune rheumatic diseases, and also the inflammatory cytokines and drugs used for treatment of rheumatic disease can lead to development of malignancies. So malignancies which release some antibodies and they release some cytokines and mediators can lead to development of some autoimmune rheumatic diseases. Also anti-tumor therapy, especially immune checkpoint, the recent immune therapy, also some chemotherapeutic drugs can lead to development of some rheumatic diseases. And it is important to understand this relationship and collaborate with oncologists for benefit of the patient. Now I will talk about the rheumatic diseases which can lead to development of malignancies. And regarding rheumatoid arthritis, there is a slightly higher risk incidence of development of malignancy, especially lymphoma and lung cancer. Regarding Sjogren syndrome, the most common type of malignancy is the non-Hodgkin lymphoma, and it particularly 13 to 18 times higher rate than general population. Regarding systemic lupus erythematosus, non-Hodgkin lymphoma, human papilloma virus associated cancers like cervical and vulvar cancers in women are the most common. Also, some studies noted lower risk of breast cancer and prostate cancer in systemic lupus erythematosus patients, denoting a protective effect of the drugs rather than underlying inflammation in the disease. Idiopathic inflammatory myopathies like dermatomyositis and polymyositis has an increased risk of development of adenocarcinoma of ovaries, GIT, breast, squamous head and neck cancers, and non-Hodgkin lymphoma, with 5.5-fold increased risk of cancer in dermatomyositis in comparison to polymyositis. Regarding systemic sclerosis, the type of cancer depends on the onset of the scleroderma, type of the scleroderma, and autoantibodies. The most common types are lung cancer, liver, esophageal, oral cavity, thyroid, melanoma, and non-melanoma skin cancer, as well as hematological malignancies. For example, in diffuse scleroderma with RNA polymerase III antibodies, breast cancer is the most common type. Regarding the stratification of the risk and understanding the mechanism of development and how to screen the patients, this table give a good guide for rheumatologists how to follow up and to screening for their patients. For example, in myositis, you can consider chest, abdomen, pelvis CT at the time of diagnosis, and for female, pelvic ultrasound in regular intervals with specific antibodies, and the consideration of gynecological malignancies. Regarding cytokines, all we know that cytokines within normal level exert normal physiologic function important for health. Increased cytokine level can lead to disease and autoimmune disease. Using biologic therapies that target cytokines can cause excessive inhibition of the cytokine with loss of function and development of the malignancy. Here, the TNF alpha plays an important role in immunity against development of activation, proliferation, and the induction of death of cancer. In this table, we can see that different anti-rheumatic drugs can, in this table, we can see that the risk of different common anti-rheumatic drugs like glucocorticoids, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, TNF inhibitors, cyclophosphamide, cyclosporin, azathioprine, and mycophenolate mofetil in relation to leukemia, solid tumors, lymphomas, skin and non-melanoma. The red rectangle means high risk, while the yellow rectangles means potential risk lymphoma and melanomatous malignancies. Regarding the malignancy risk and drugs, non-cutaneous malignancy risk development with anti-TNF inhibitors is lymphoma, stikinomab is prostate, colorectal, and breast cancer. Cutaneous malignancy risk in inflammatory bowel disease receiving anti-TNF therapy, we can see increased risk of melanoma. Regarding malignancies that present with rheumatic diseases, solid tumors can present with rheumatoid-like syndrome, and the carcinoma of the lung can present with Jacquard-like arthropathy, similar to Jacquard arthropathy in systemic lupus erythematosus. Myeloma can have a myeloid arthropathy. Lymphomas and Hodgkin disease can present with adult onset still-like disease of fever and rash. Leukemias, lymphomas, and myelomas, any proliferative disorders, cancer chemotherapy can present with secondary gout due to high turnover of nucleoproteins. Thymoma, Hodgkin disease, carcinoma of the lung, breast, and ovary can present with systemic lupus-like syndrome. Myeloproliferative and lymphoproliferative disorders can present with small vessel vasculitis. Hairy cell leukemia can present with medium vessel arteritis. Various types of cancer can present with severe Raynaud's phenomena, digital necrosis, and reflex sympathetic dystrophy. Many lymphoproliferative disorders have an erythema nodosum presentation. Lung carcinoma, melanoma, and some myelomas can present with scleroderma-like skin changes. Myeloproliferative and lymphoproliferative disorders, the patient can have eosinophilic fasciitis. Regarding chemotherapy and the development of some rheumatic diseases, this table summarizes the most important points regarding bleomycin. Patient can present with Raynaud's syndrome, as skin thinning. Cyclophosphamide, patient can have arthralgia and myalgia. Regarding the immune checkpoint inhibitors, which are receptors that are present on the surface of the immune cells, like the protein this ligand, to check the action of the T cells. Tumors can present ligands that bind to these receptors and inhibit T cell function and destruction of the malignancy. Inhibition of these checkpoints with specific antibodies lead to activation of T cells and exert tumor dysfunction. Checkpoint inhibitors can present with different autoimmune syndromes, and this table summarizes these presentations. Regarding the metastatic bone disease, we have osteolytic metastasis and osteosclerotic metastasis. The metastatic osteolytic cells release osteoclast activating factors, activin A and other epithelial growth factor to stimulate osteoclastic proliferation and inhibit the osteoblast with promotion of the bone destruction, and the osteoclast in turn will release bone morphogenic proteins, transforming growth factor beta, insulin growth factor 1, that stimulate the growth and the proliferation of tumor cells, which in turn release other factors to stimulate pre-osteoclast to develop as osteoclast, and more bone destruction spread and the growth of the tumor in the same time. On the other side, the osteosclerotic tumors like prostatic cancer will secrete Wnt signaling bone morphogenic proteins that stimulate osteoblast, which release growth factors that stimulate tumor cell growth with more deposition, spread, bone destruction, and metastasis. The underlying mechanism of pain is related to direct tumor-induced microfractures and irritation of the periosteum. Osteoclastic proliferation with release of lactate and hydrogen atoms that binds to TRPV1 receptors, for example, that stimulate the nociceptive neuronal pathway and relate dorsal root ganglion with activation of pain pathway. Also, tumor cells that exhibit the Warburg effect, lactate production and hydrogen production that binds to the TRPV1 receptors, for example, with irritation and activation of nociceptive pain. The tumor cells also produce nerve growth factor and interleukin-1 beta and TNF-alpha and other mediators that can cause sensitization and activation of the receptors. Regarding the treatment, the rheumatic diseases that present with and complicate with malignancy, we should consult the oncologist, and the oncologist should start the treatment against malignancy either with stoppage of rheumatic drugs or continuation, and we'll show in table next table as an example. In cases of current malignancy presented with paraneoplastic syndrome, we should ask ourselves in consultation with the oncologist if the malignant disease is in remission. Yes, there is high risk of if there is high risk of relapse of the malignancy, and if no, you can use immunosuppressive drugs to treat developing rheumatic disease. If yes, consult an oncologist and start cancer treatment. If the current malignancy is presented with neoplastic syndrome, treat the malignancy. If not, ask the oncologist if the rheumatic disease is developed by the treatment. If yes, change the anti-neoplastic strategy. If no, consult the oncologist and start anti-rheumatic therapy. Regarding the checkpoint inhibitors syndromes related inflammatory arthritis, you can start with NSAIDs, intra-articular steroids, if monoarthritis or 3 affected joints, low dose prednisolone, moderate to severe or resistant higher doses of prednisolone. You can add methotrexate, leflunomide, hydroxychloroquine, TNF inhibitors, and interleukin 6 inhibitors. In myositis, for example, you can use high dose oral intravenous steroids, plasmapheresis, rituximab, and mycophenolate. Regarding the anti-rheumatic drugs and strategy during treating malignancy, for example, anti-TNF inhibitors, if we treat a solid tumor, we continue anti-TNF inhibitor and stop if cytotoxic or metastatic development of the tumor. In cases of ustekinumab, when with cutaneous malignancy, in non-melanoma, continue ustekinumab. Regarding the metastatic bone pain, we can start with analgesics, anti-resorbatives, anti-epileptics. The anti-resorbatives inhibit circulating tumor cells and inhibit the invasion of bone marrow sinus and expansion of tumor cells, and inhibit tumor cells growth and micrometastasis, and inhibit metastasis enlargement and prevent bone destruction. And this table discusses the mechanism of action of bisphosphonates and the denosumab monoclonal antibody against rancil in treatment of metastatic cancer pain. The take-home message is first, collaboration between rheumatologist and oncologist to detect the onset of development of malignancy and how to screen your patient. The second, collaboration during the treatment is important for benefit of the patient. And thank you very much.
Great. Thank you, Dr. Abdullah, for this nice overview. You made it simple, yes. When you see all these antibiologics and anti-neuralgics and all these anti-rheumatic factors and anti-rheumatic diseases, it's interesting to have this overview and this summary about it. I have a question. If somebody, anyone who has a question? Dr. Abdullah, Dr. Rahman, Dr. Mustafa. If not, I have a question. How do you manage all these new biologics? Like, for example, we know that there are some new anti-TNF drugs coming in the market very soon regarding osteoarthritis. Every day we have new molecule. How do you rely on the? Is there any guidelines? Is there any anything that you base your decision on?
Guidelines is not clear till now about the development of malignancies. You know, some research say research sponsored by pharmaceutical companies say very low risk and no fear from development of malignancies, so you can use the drug safely. The development of malignancy is due to the chronic irritation and inflammation by the original disease. And some research say no, there is some risk with these drugs, and until now the dilemma of controversial research is not solved. It is important to understand the underlying molecular mechanism for action of the drug and follow-up of the patient, and risk factors like smoking or alcohol drinking or other factors like HCV in Egypt might play a role in development of hepatocellular carcinoma, not the TNF inhibitors itself or rheumatoid arthritis per se.
Okay, perfect. Any other questions in the panel, from the panel? Any interventions for these patients?
I have comments.
Yes.
Thank you, Dr. Abdullah Alam, for this amazing lecture. It was very, very amazing to know this, to know a lot of things about your presentation. And I have some question in your practice. How do you manage off this problem with malignant, for example, malignant cancer pain syndromes in rheumatological disease? Because the problem is we have two problems: the disease and the how to manage the disease, and how to manage the probability, for example, to having malignancy with treatment.
Again, repeat the question, please, Professor Ahmed. Please repeat the question again.
Repeat the question, Dr. Ahmed.
Okay. My question is, for example, in managing rheumatological disease, when you start managing, for example, rheumatological disease, you start with the treatments. For example, you start with, for example, immunosuppressive treatment. You start with treatment that we can use in malignancy disease. But this treatment can lead us to, for example, to malignancy disease or tumor with the same treatment. And how do you do to separate, for example, the problem, the rheumatological problem, and the cancer problem? It's very, very hard to. It's very hard to separate, for example, in our practice.
Okay, I saw some patients with rheumatoid arthritis in my health insurance clinic that developed breast cancer. So the oncologist did the radical mastectomy and asked them to stop rheumatoid arthritis treatment and give them chemotherapy for the lymph node metastasis. And the oncologist told them that the chemotherapy will ablate the immune system, putting it in remission for rheumatoid arthritis. And I saw 2 cases in complete remission after chemotherapy for malignancy for 5 years till now. So if the patient developed cancer during the course of rheumatic disease, the protocol for treatment of cancer can sometimes abort the autoimmune process, because the doses in cancer is very high than rheumatologic disease, cyclophosphamide or methotrexate. We use very low doses in comparison to oncologists. So if you increase the dose, you can kill more immune cells and have remission of the disease, of rheumatic disease.
Okay. Thank you.
Thank you.
Dr. Ammar, you are mute.
I said my question was, what are your options for interventions for these patients? What do you do in your practice when you have a patient coming for cancer with rheumatoid arthritis, for example? Do you use steroids, where you know that steroids are reducing the immunity? Do you have any guidelines for that?
Protocols of treatment of malignancies like hematologic malignancies.
We need the mic.
Some protocols of treatment of malignancies like lymphomas use large dose of corticosteroids. So we refer the patient to the oncologist, and the treatment is oncologist side. And if the patient develop neuropathic pain or neuritis from the chemotherapy or myopathy or something, we start treatment as a rehabilitation. I have both specialty rheumatology and physical medicine and rehabilitation. So treatment is collaboration. Sometimes some patients receive chemotherapy and receive rheumatoid arthritis treatment as shown in the table, maybe anti-TNF inhibitors continued in some types of malignancies. Leflunomide and methotrexate can be continued also in certain types of malignancies. No, except of increasing load on liver, GIT, toxicity, and blood pancytopenias, risk is very high.
Yeah. At the same time, when you have a cancer patient and you use high dose of narcotics, for example, still the immunity is out. So again, you have another the reverse problem with the reduced immunity from the cancer, which can affect also the rheumatoid factors and the rheumatoid disease.
Yes, it help remission. Most of patients enter long-term remission after cancer treatment. It's because it ablates the rapidly dividing cells, and you know that immune cells are rapidly dividing cells. They are ablated with cancer treatment. High doses of cyclophosphamide, methotrexate, bleomycin, and other alkylating agents can, but patient might develop secondary gout from these chemotherapeutics and have a polyarticular presentation to the clinic, might mimic rheumatoid arthritis or psoriatic arthritis, and should be differentiated at this time.
Okay, any other questions? Dr. Ahmed, Dr. Mustafa, Dr. Usama? Well, I think the panel, yes, Dr. Mustafa.
Yes, I have
Go
a
ahead.
little question. Yes, for me, I am an anesthesiologist, and I have some patients with pain problem. I'm not a rheumatologist, but what I learned from Dr. Abdullah's lecture is that maybe some patients with cancer and inflammatory tests which are high, maybe to discuss a consultation with a rheumatologist. I don't know what do you think.
Yes, sometimes the tumor produce autoantibodies, so false positive test can present without any clinical presentation. So it is important for rheumatologists to consult rheumatologists to interpret the clinical presentation and the laboratory findings good. Sometimes I might need MRI imaging of the joints to exclude true inflammatory erosive disease. You know, sometimes the clinical presentation is hazy and the lab is not conclusive or false positive, and the patient present with polyarticular complaint, and I order MRI hand and wrist joints to see bone marrow edema, loss of cartilage, erosions, tenosynovitis, tendon subluxation, and other signs of erosive autoimmune disease.
Thank you.
Okay, great. We had a very good interaction, 2 hours of interactions and discussions, going from the pharmacological to the non-pharmacological options and management of cancer. Then we went into the deep in science with rheumatology and cancer combined. And we learned a lot from this interaction. I think
a presentation for all to read the tables and slides.
Very good. I think Dr. Ahmed, he has a library now with all these lectures that he has. So probably, I think in their website, they need to offer this to their attendees and their doctors. It's a young society. I'm glad to participate in helping, supporting, and enhancing the knowledge about pain, acute and chronic. And we are glad in Gulf Pain School also to collaborate to help with any sort of help that you need. And we're looking for traveling again and seeing each other live. Okay. Dubai is already open. Now we have all the conferences open, and probably Abu Dhabi Sure. Taiwan, of course, it was open and remains open. They don't have
But there's
any.
2 weeks quarantine.
Yeah, probably the quarantine is gonna
انا
go
ودكتور
now.
احمد
Yes.
امين الغلابه، اي حد يعزمنا بقى.
Yes.
الدنيا عندنا
So
Yes.
looking forward to
You are
that.
welcome, Dr. Abdullah. In 19 and 20 of December, we have neuromuscular ultrasound organized by the Professor Kevin.
Next week.
So you are welcome to
It's too
come
short.
all.
Too short. So the last word is for Dr. Ahmed, the president of the society. Please, Dr. Ahmed, you have the word to close the session.
Okay. First, thank you, Dr. Ammar, for your support and for all the time you have support us for the Moroccan Academy of Pain, and are grateful for that, and are very happy to have you as mentors to our society and as brothers in our Moroccan pain physician. Thank you for you, and thank you for our faculty, Dr. Abdullah Kharabsha from Taiwan and from Jordan. And thank you very much for your great lecture.
Very much.
Hope to see you again. Thank you, Dr. Abdullah Said Allam, great friend from Tanta, from Egypt. He's now. Yes. We don't hear you very much, Dr. Abdullah. Thank you very much for your time. Thank you for all your great lecture and your support. Thank you, Dr. Boutbouch Mustafa from Agadir, Dr. Osama from Casablanca, and and Amin Rizqullah is our host and our organizer here in Morocco. Thank you, Amin, for your great organizer, and thank you for all the attendees. And hope to see you again. Hope to see you in real life for perhaps next month or next year. And thank you very much for all the attendees and all of you from Morocco. Thank you. Have a good day. Thank you.
Take care. Bye-bye.
Take care.
جزيلا.
Good night.
سلام.
Night.